with that, thank you all. And I'm looking forward to having an interesting webinar. Thank you.
Thank you, madam. Thank you for the welcome speech. And I am waiting for Dr. Raj Rege to connect here. I think there is some technical issue. And I think we can welcome our first speaker. If Dr. Prajakta is ready, can start with the presentation.
Voice not audible.
Sir, Dr.
Yeah.
Dr. Parijat is the first speaker, sir. So
Okay.
he will first and then I speak.
Okay, fine. Okay, we welcome our first speaker, Dr. Parijat Roy. He is an MD in psychiatry. He is a PDF in de-addiction. And today, Dr. Parijat Roy will be speaking on the understanding of nicotine addiction, the biopsychosocial model, and he will also touch upon the biopsychosocial model of nicotine addiction, and in the process discuss why nicotine use is so rampant and what makes it so difficult to quit. Dr. Parijat, if you are ready, you can start with your presentation. Thank you.
Hello, am I audible?
Yeah, very well.
Hi, good afternoon, everyone. So just give me a second's time. I would like to share my screen. And is it visible?
Yes, your slide is visible, but it is not full screen.
It's not full screen. 1 second. Is it full screen now?
No. I think when you shared, you have clicked on Windows. You should not click on Windows. You should click on entire screen. Then it will become full screen.
1 second.
Stop sharing.
Yeah.
Click again on share.
Yeah.
Now
Share
you are
screen.
able to see. Yeah, you are able to see Chrome, Windows,
Yeah.
and entire screen. Click on entire screen.
Entire screen. Got it.
Yeah.
Perfect. Is it visible now?
Yeah.
Hi, thank you so much. So very good afternoon, everyone. Before I begin my presentation, I would like to extend my heartfelt gratitude towards Indian Dental Association, Thane branch, and Dr. Shobha Nair, Madam, President, Bombay Psychiatric Society, for inviting me for today's presentation, a presentation on World No Tobacco Day. As you can see on my screen, the topic for today's presentation is understanding nicotine addiction, the biopsychosocial model. So let us first look what the biopsychosocial model actually means. Here in the figure, you can see three circles, and at the confluence of these three circles lie mental health. Thus, to summarize, biopsychosocial model is nothing but a framework that emphasizes the interconnectedness of biological, psychological and social factors, understanding and treating illnesses, and promoting overall well-being. Here, we move beyond focusing solely on biological causes and consider the influence of mind, emotions, and our social environment on health and disease. This is somewhat of a newer concept, and it was given by an American psychiatrist, Dr. George L. Engel, in the year 1979. And the aim was to identify high-risk population, to identify the predisposing and perpetuating factors, and also to devise patient-specific treatment strategies. Now, the question is, why do we need to understand the biopsychosocial factors in case of nicotine addiction? Well, I don't think the answer should be that complicated. Nicotine, as we all know, is the most commonly used substance, not only in India, but worldwide as well. Approximately 22.3% of global population, which corresponds to 1.25 billion adults, consume or are dependent on tobacco. The Indian scenario is even worse, with 28.6% of our population being dependent on nicotine. Nicotine leads to 8 million lives lost annually. Not to forget the comorbidities that we also deal across. So this is why it is important that we understand each and every factor that is associated with this menace, that is tobacco dependence. So before I go into the actual factors, let us quickly look into the diagnostic criteria for tobacco dependence. So as we can see, there are 11 criteria, which also includes terms such as tolerance and withdrawal, which we are going to discuss subsequently in our future slides. So out of these 11 criteria, if we are meeting at least two criteria, and that too for a period of 12 months, a diagnosis of nicotine or tobacco dependence can be made, right? So with this in mind, let us first look into the biological factors. And where do we start? We start with this beautiful flower, pink, beautiful flower with plump green leaves. This is nothing but leaves of Nicotiana tabacum, or nicotine as we call it in our day-to-day practice. This plant, this flower, has its origin in Central and South America. So there it was used by the priests, it was used by the warriors, it was used by the workers. In India, it was the Portuguese who brought it here. And the history of nicotine is not very old in India. It was in the year 1509 when the Portuguese brought it ashore, and rest, as they say, is history. So what is it that makes nicotine such an irresistible drug? What is it that makes it so easy to get in and so difficult to get out? This. If we can see, nicotine is a broad spectrum chemical. It acts on virtually all the neurotransmitters, neuroreceptors that are present in our brain, which includes dopamine, which is responsible for pleasure and arousal, on norepinephrine, which is responsible for stimulation and arousal, on glutamate and acetylcholine, which is responsible for cognition, for memory, on GABA, which has very good relaxation properties, on serotonin, which regulates our mood, and also on endogenous opioid receptors, which are responsible for analgesia. So when we ask our patients to quit nicotine, we are also devoiding them of all these effects. Apart from this, nicotine has a very short half-life, approximately 2 hours, thus warranting repeated exposure. It also readily crosses cell membranes and thus binds very tightly to the nicotinic receptors. The nicotine products themselves are manufactured in such a way that their pH is optimized to maximize the absorption of nicotine into our bloodstream. Also, the size of cigarettes and pouches are optimized so as to give the maximum amount of high or euphoria. From nicotine, we come to the second biological factor, that is the nicotinic receptors. As we all know, nicotinic receptors are a subfamily of cholinergic receptors. It is basically a ligand-gated ion channel. The ligand here being nicotine itself. So as soon as nicotine binds to this receptor, the receptor opens up, there is influx of sodium and potassium, and the cell membrane gets depolarized, thereby leading to further action. These nicotinic receptors are abundant in the reward pathway, that is the pathway between ventral tegmental area to nucleus accumbens to prefrontal cortex. And this is why this nicotine is so addictive. Here is a detailed version of what happens inside the reward pathway. So as we can see, nicotinic receptors are present on the dopaminergic neurons in ventral tegmental area, very high concentration. As soon as nicotine binds to these receptors, they activate the dopaminergic neurons. As a result of which, there is massive release of dopamine in our reward center, in the nucleus accumbens. Result of which, we get a high, we get euphoria. And this high is much higher than what we get from, say, a natural reward. Thereby, this substance hijacks our brain, and our brain starts focusing on how to procure, how to consume the drug, and leaves everything else behind. Right? Now, here, there is also something known as tolerance that we had mentioned in the diagnostic criteria. So what happens is, as we consume more and more tobacco, the receptors get insensitive. So to get the same high, we would require a higher concentration of nicotine. This is what we call as tolerance. Now, to overcome this, the brain also acts very smartly. It starts recruiting more and more nicotine receptors, right? So in place of one, there are now 10 receptors doing the same activity. However, there is a problem in this. Whenever a receptor comes back from a desensitized state to a resting state, there starts craving. This is how craving starts. So initially, there was just one receptor which was getting moving from the desensitized to the resting state, thereby the craving was, say, X amount. Now, after prolonged exposure to nicotine, we have 10 receptors at our disposal. And when these 10 receptors go back to the resting stage, the amount of craving we get is 10 times higher. And we do not consume nicotine at this stage, we get something that we know as withdrawal. And trust me, these withdrawal symptoms are extremely distressing. Severe enough to warrant a continued nicotine use. The common withdrawal symptoms that we see in nicotine dependence are anxiety, irritability, difficulty in concentration, appetite changes, restlessness, sleep changes, and depression. Apart from that, certain physical symptoms like tremors, like palpitations can also be seen. Moving on, let us now see the third biological factor, which is genetics. As we say, genes never lie. So nicotine has a very high heritability to the extent of 50 to 75%. However, there is no single gene that has been identified, and it is assumed to be polygenic in inheritance. The common genes of interest include the cytochrome P genes, the nicotinic receptor genes, the opioid receptor genes, mu1, and dopaminergic genes. So all these genes partly contribute to the high heritability of nicotine dependence. Coming to the last biological factor, as Shobha ma'am had just mentioned, comorbid psychiatric disorders. The prevalence of nicotine use in patients with severe mental illness is as high as 75 to 80%, right? So whenever we are coming across a patient who comes to us for nicotine dependence, it is imperative that we inquire for the presence of any psychiatric disorder. The common disorders that we see in association is psychosis or schizophrenia. And the reasons why a patient of psychosis consumes nicotine is it alleviates negative symptoms, it alleviates cognitive symptoms. A lot of time, negative and cognitive symptom could be because of our own medications. So nicotine alleviates the side effects as well. And also there is a phenomenon known as sensory gating, wherein nicotine enables or helps the patient to ignore the auditory hallucinations that might be there. So this is what we call as sensory gating, and a lot of times our patients consume tobacco just for this. Apart from psychosis, ADHD, inattention, hyperactivity. A lot of our patients who start early have a comorbid diagnosis of ADHD. And if it is not treated, it can lead to nicotine dependence and dependence on other substances going in. Also, anxiety and depressive disorders can also lead to continued nicotine use if they are untreated. Right? So in biological factors, we have nicotine itself, the nicotine receptors, genetics, and various comorbid psychiatric illnesses. Moving on, let us now look into the second of our triad, that is the psychological factors. In psychological factors, it is important to know that these are as important as the biological factors, and it influences the initiation, maintenance, and quitting behaviors. Psychological factors include the role of cognitive thoughts, attitudes, personality types, psychosocial stressors, and emotions on tobacco use and its maintenance. Psychology says that tobacco dependence is a learned behavior. So initially, when we are consuming tobacco, we get a high. So that is positive reinforcement. Going ahead, once we decide to quit or cut down our tobacco use, we get unpleasant withdrawal symptoms. Now, we continue our tobacco use just to avoid these withdrawal symptoms. So in short, initially it was the positive reinforcement. Later on, it was avoiding the withdrawal symptoms, which perpetuates our tobacco use. Also, there is something known as pairing. That is, with repeated use, certain situations or events or even people can become a strong cue because they have become associated with the pleasurable effects. And thus, going ahead, they can act as triggers. These can be our friends, these can be shops, these can be certain situations. And once we are faced with this, the trigger comes, the craving initiates, and then we go on and consume tobacco. So in relapse prevention, dealing with triggers is something that we always focus on. Now, coming to certain attitudes and beliefs. So it includes how we perceive tobacco, whether we perceive it in a positive way or in a negative way. What are our intentions? How strong are our motivations to quit tobacco? Whether we have the self-efficacy to refuse a cigarette, to refuse nicotine. Whether we have that self-efficacy to quit a tobacco product. And also risk perception, that is perceived vulnerability and perceived benefits. For risk perception, what we do in practice is we ask the patient to draw a balance sheet. Advantages of tobacco, advantages of quitting, disadvantages of tobacco, disadvantages of quitting. So they write it, whatever they feel, and they then come up with that balance sheet. The advantage of balance sheet is the patient himself is able to weigh the pros and cons. We do not tell them anything. They themselves come up with the answers. And once they are able to weigh the pros and cons, the motivation automatically improves. Moving on, personality characteristics. No substance dependence, no discussion on substance dependence is complete without mentioning personality traits. In tobacco dependence, people who are impulsive, who have a high degree of hostility, who have high neuroticism, that is, they experience negative emotions more readily, who have low agreeableness, that is, they do not trust, they are uncooperative, they lack empathy, and who have low conscientiousness, that is, they are disorganized, they lack discipline. If the person has any of these personality types, they are more at risk of developing tobacco dependence. Also, these personality types use particular defense mechanisms like rationalization, like minimization. अरे सिगरेट पीने से कुछ नहीं होता है, मैं तो 2 ही सिगरेट पीता हूं, बाकी दुनिया तो बहुत और नशे करती है. That is minimization. सिगरेट पीने से टेंशन कम होता है, कुछ नहीं है, सिगरेट टेंशन कम करने के लिए पीता हूं. That is rationalization. So a lot of people, a lot of patients who are dependent on tobacco use these forms of defense mechanisms as well. Now, coming to psychosocial stressors, and childhood adversities or abuse is one of the very important psychosocial stressors. Until the time they are focused on or an effort is made to resolve them, this dependence usually is difficult to break. Also, socio-economical stressors, and that is why the prevalence of tobacco dependence is higher in low-income groups. Non-specific stressors also contribute to the ongoing cycle of nicotine dependence. To the last of our triad, that is the social factors. So we start the social factors with the demographic factors, and in this, the most important is gender. Research says that prevalence of tobacco use is higher in males than in females, to the extent of 3 to 5 times. It is even higher in smoking compared to smokeless tobacco. The reason is smoking women is quite frowned upon in our society. Apart from gender differences, education and income also play a vital role in maintaining tobacco dependence. And lower the education, higher the prevalence of tobacco. Lower the income, higher the prevalence of tobacco. So these are some of the socio-demographic factors. Next comes a very important social factor, that is social influence. That is the direct or indirect effect one has on the other person. So if my social influence is very persuasive, that can be good or bad. If the persuasion is, please do not smoke cigarettes, please do not take tobacco, my chances of quitting will be very high. On the contrary, if the persuasion is, take tobacco, take cigarettes, nothing is going to happen. If the communication is in that respect, then my chances of quitting will be very low. Also, endorsements by so-called celebrities, wherein they highlight the positives, so-called positives of substance use, they are imitated by a lot of our patients, especially adolescents and young adults, and their own behavior is modeled on that. Hence, it is very important that these celebrities also become a little more responsible and refrain from advertising or endorsing such brands. Next is the role of peers and social networks. And by peers, I mean friends, romantic relationships, and broad social network. As per research, role of peers and social networks is the biggest during adolescence, particularly younger adolescents. And Dr. Prajakta is going to focus on that. 88% of people who smoke start before the age of 18. So you can imagine the role of peers. Also, it is noted that girls become more readily influenced by peer groups rather than boys. The role of parental use, again, very, very big. Discounting the genetic part, genetic or heritability part is there. Apart from that, if I see my parent, if I see my dad or my mom smoking, I tend to model or I tend to imitate that action. And that leads to a higher risk of me having nicotine dependence than someone whose parents are not smoking. Fortunately though, parental quitting is also associated with the child or the adolescent quitting later on in their life. Now comes the environmental factors, and it includes co-workers, friends, and family. If they are smoking, the likelihood of us smoking also increases. If they are abstaining, then it increases our chances of abstinence. Social non-acceptability of smoking. If my social circle looks down upon me for my tobacco use, my chances of remaining abstinent becomes higher. Presence of a non-smoker or smoker spouse, that also plays a big role. Access to cigarettes and smoking environments. That is why we always tell the patients that, okay, if you have to smoke, go and buy from a tapri. Do not keep a packet with you, because if you have access to that, your chances of quitting will be very less. Household smoking bans related to smoking cessation. So if my household has a rule that no, you cannot smoke or you cannot consume tobacco inside my house, then again the individual has to go out for that smoke. That automatically reduces the chances of me consuming or continuing my tobacco dependence. Nature of jobs, especially jobs which are boring, which are mundane, which do not require too much of our frontal cortex activation. Those jobs have a higher prevalence of nicotine dependence. For example, drivers, manual laborers, factory assembly workers. In them, the prevalence of nicotine dependence is very high because the job inherently is very boring. Also, workplace bans is related to greater quit attempts. So if the workplace has a very stringent rule that no, you cannot consume within the duty hours or within the campus, the chances of the individual remaining abstinent becomes higher. Also, role of built environment. So is it easy to find a place to smoke? If yes, the chances of smoking or tobacco dependence becomes high. If no, then it comes smoke. So installing cameras or installing smoke detectors, that could be one of the ways to modify the work environment so that the prevalence of tobacco dependence comes down. Now, the last is cultural factor. So how readily one's culture accepts one's tobacco dependence. In Sikhism, smoking is considered a sin. It is considered a taboo. Thus, in those areas, in them, the prevalence of smoking is inherently low. However, in Eastern India, in the Northeastern states, tobacco is a part of their culture. Especially smokeless tobacco, it is given as a gift. It is a part of a lot of religious and cultural programs. And that is why the prevalence of tobacco dependence is higher in those areas. So if my culture is something which is aversive to tobacco use, automatically my risk comes down. If it is something that is inherently does not see tobacco dependence as a taboo, as something bad, my chances of tobacco dependence becomes high. Thus, to summarize, biopsychosocial factors need to be considered, not only identify at-risk population, but also to identify the risk factors which are precipitating or perpetuating the illness, and also design interventions aimed at it. Remember, most of the biological factors are non-modifiable, but psychological and social factors are modifiable. So if we only focus on the biological factor and ignore the psychological and social factor, our treatment will be low, right? So on World No Tobacco Day, let us all take a pledge that we will help our patients out in whatever way possible. And if we ourselves are a party to this addiction, let us take a pledge to start the change from within. Before I end my presentation, I would like to inform our esteemed colleagues that our hospital, KM Hospital, has a dedicated tobacco cessation clinic that runs every Wednesday morning 8:30 to 10:30 at OPD number 40, second floor, OC building, opposite Tata Memorial Hospital. And we have free of cost varenicline, bupropion, and nicotine tests available at our sectors. So if you have patients who are struggling with nicotine dependence, please refer them to us so that we are able to tackle this menace together. With this, I would like to end my presentation. Thank you so much for your patient listening. And again, thank you for inviting me to be a part of this session. Thank you.
Yes, Dr. Raj, you can start.
Everyone. This is Dr. Raj Rege, CD convener, IDA Thane branch. First of all, sincere apologies for the unstable net. This took me a little bit of time. Maybe this is the first webinar where I'm introducing the speaker after he has gone ahead and delivered such a stellar performance. Thank you, Dr. Parijat. Dr. Parijat is really a really good one, a really eye-opener, I would say. Dr. Parijat, to introduce him, he has been a member of the Department of Psychiatry. He is an assistant professor there. He is also a part of the Drug De-Addiction Center of Excellence at KM Hospital and GSMC. He's been around for 5 years. He's done his postdoctoral fellowship in addiction psychiatry and has more than 15 plus research articles in both international and national journals. Thank you so much, sir. Great to have you on board.
Thank you.
And Dr. Shobha Nair, I heard your presentation, your welcome address. We welcome you, ma'am. IDA Thane is more than happy to join hands with BPS in curbing this menace of tobacco. Thank you so much, ma'am. And thank you personally. Thank you for the warm words of appreciation. Our next speaker is going to be Dr. Prajakta Patkar. A little brief info about her. Dr. Prajakta Patkar has been a part of BYL Nair Hospital and TNMC as an assistant professor. She also holds various posts on different organizations like ICAM, IPS West Zone as a member serving different functions. She also happens to be the honorary secretary of the Bombay Psychiatry Society. She has done, as part of her qualification, she has done her psychiatry post-graduation, and she has gone ahead to do her postdoctoral fellowship in child and adolescent mental health. And also a very good thing about Dr. Prajakta is she is going to enlighten us today on how tobacco addiction is going to cause a difference with the adolescent mind, something that we need to know, because as dentists, quite a lot of our patients who undergo de-addiction are adolescents. Adolescent minds and adult minds function differently. So over to you, Dr. Prajakta. Give us some more light, please.
Thank you, Dr. Raj. Thank you for the IDA Thane for having us here, and we are really grateful, like Shobha ma'am has already mentioned, for this wonderful collaboration on this really important day, which is the World No Tobacco Day. And with such collaborations, I think we would go ahead with making bigger differences rather than just talking about these problems on on institute levels or in our own programs. We need to join hands and do something together, and that's exactly what we're doing here today. So thank you so much, Manisha ma'am and Dr. Raj, for arranging this so effortlessly. Of course, net issues are always going to be there, and we can't do anything about it. I'm sitting here with no electricity as of now, but so yeah. Before I do start my presentation, let me just share my screen. Is my screen visible?
No, not visible.
Visible, doc.
Is it visible now, sir?
Yet. Click on share.
I did that, sir. I did that.
Then out of the three options,
Yes. Yes.
Chrome,
Yeah,
Windows,
I did that too.
entire screen you selected?
Yes, I did that. Is this visible now?
No. You have to click on entire screen and then below share button. Below that, there is share button. You have to click on that again.
I did that also. Is it visible now, sir? Is this visible now? Yes. Okay. Sorry, this is something that I always keep struggling with. Yes, but thank you so much, Parijat, for giving us such an elaborate yet very simplified version of how addictions really work. And it's so complicated, the world of of treating addictions, that we almost always call it as a revolving door phenomenon, because there are many times that patients come in, we try to treat them, they do stop whatever addiction it is, and they're after a few months or maybe a few years, they are back into your clinic. So it's almost like a revolving door phenomenon. But the important point is that more and more people are seeking out help now, and it's the earlier you seek help, the easier it is to stop this revolving door phenomenon, because the more you get caught up into that loop, it becomes more difficult for the psychiatrist, the psychologist, the other social workers, the family, their support system to work around this, in removing them out of this vicious circle. Hence, we need to focus on them as early as possible. That's the whole idea why we are talking about teen temptations today, which is the rising tide of adolescent addictions. And so why do we need to focus on our teens? India is one of the largest adolescent population in the world, with almost 253 million adolescents. Yeah, that's the number that we have in India. Every fifth person is between 10 to 19 years. And if we do focus on this vulnerable group, we as a nation are going to stand to benefit socially, politically, economically, in improving the country's support system and keep it. I mean, we are rightly going towards from being a developing to a developed nation, and we need to focus on our teens for that. So that's the whole idea behind this small presentation. The world is studying about nicotine addiction, and they're almost UNICEF is almost saying that we are reaching tobacco use in children and adolescents especially is reaching pandemic levels. I don't know if you any of you saw this very interesting reel which was going on around last 2 weeks ago, where there was this it was a foreigner who was visiting somewhere around Delhi, and he was going around and he was just randomly videotaping interesting things in Delhi, and he found he incidentally saw on the road two very young boys who were as old as about 8 to 9 years, and both of them were, you know, like youngsters. They're just cycling on the road, and they both had vapes in their hand. And he got very, very fascinated that these two youngsters are having these vapes in their hand, and he asked them that, you know, where do you you're smoking? Are you serious? And they said, yeah, but it's, why are you so surprised? This was a conversation in Hindi, of course. So the boys said, "हाँ, आप इतना क्यों ये कर रहे हो?" So, and then obviously the video went ahead where he's following them and asking them where did they get all of this, and then they just ran away. But this video got very viral a couple of weeks ago, and that is very scary because absolutely no one is keeping check on tobacco. Cigarette smoking, BDs, vapes, this has become so rampant in children and adolescents every day in India and abroad, that it becomes very pertinent for us to talk about it. India is the third largest producer and consumer of tobacco in the world, and that gives us more you know, access to it. In tobacco has, like Dr. Parijat said, that it has been in socially accepted in our system any which ways from generations, where we have hookah or we have other forms of tobacco which are you know, used by many adults in the family, and that's quite normal. That gives access to the children. They know about it. They know that you can do it and not be frowned upon, and maybe that also adds to this problem. So if we look at statistics, there are about 20 million children who are estimated to be addicted to tobacco, and this is a survey which was done by the Indian government. So this is we are talking about India, and the tobacco industry, the prime targets of them or their you know, kind of sale is children and adolescents, and almost 5,500 new users are added every day. So their usual, they start smoking, and within a matter of 1 or 2 years, it's almost daily smoking. So the interval between the first cigarette consumption and daily smoking is as little as 1 or 2 years. So, I mean, that's quite scary. So 20% of them might quit, you know, eventually, but it might not be more than a month. We need to focus on that. So the UNICEF is also saying that it's a very critical game changer that India as a nation needs to focus on. Obviously other things, but one of them is the adolescent health. So why is adolescence so difficult? And it is, I mean, I'm sure all of us, few of you might have adolescents at home as kids or as siblings or someone in the family, and we are of course like, oh, he's a teenager, she's a teenager, of course it's going to be difficult. But of course they are going through a period of transition from childhood to adulthood, and this is marked very commonly with a lot of behavioral changes. There's a lot of changes happening within their body and their brain, and that makes them much more vulnerable to risk taking, novelty seeking, peer association, peer influence. And this is thought to ease, I mean, usually they ease successfully into independent autonomic adults, but this crucial period is the deciding phase where they can go a little haywire. Either they come back or they don't, but this is the time where it's very difficult for them to not try you know, interesting or fancy things, right? This is something what you probably, if we have a cross section of an adolescent brain, this is how it would look like. Again, this is just a fun thing, but during this developmental period, the brain is very sensitive to novel experiences. So major experience and all of these major experiences depend, they are plasticity dependent. So these are the ones which help in executive control and decision making, which is there in the prefrontal cortex of the brain. If you see this diagram, the prefrontal cortex is almost always in adolescence, almost always occupied by love and addiction and self-image, blah blah blah. But it's important that the prefrontal cortex is developing, and it does seek out to novel experiences. The imbalanced maturation of the subcortical emotional and reward focus systems, as well as cortical executive impulse control system, is the underlying reason why an adolescent is more vulnerable to risk-taking behaviors, particularly in social settings. So this time where there is an imbalance in the maturation of we just understood reward systems from Dr. Parijat, and the emotional system from Dr. Parijat, and that is how do they control that? How do they make that decisions? How do you control a particular impulse? That's very difficult for an adolescent, especially if the environment around him or her is a little more problematic. So an adolescent on a daily basis is having a lot of challenges. They might say otherwise, but we are living in different generations now, that it's not just about growing up. They have a lot of academic pressure, lot of expectations, peer pressure, social relationships. They are at the same time, they are trying to work on their own emotional, mental well-being, trying to build more coping skills. But technology and digital challenges are availability is something which adds to the existing problem. So what are the factors related to substance use during adolescence? I think Dr. Parijat really explained us really well about how the biopsychosocial model comes into picture when we are focusing on addiction. But during adolescence, there are other things that the child is also kind of struggling with regards to his or her identity, with regards to coping up with other stresses which are going on around him or her, and there are the different hormonal changes. These all collectively make them more vulnerable to falling prey to maybe a substance use or an abuse. So why do we need to cut it down here? Because any child or any adolescent which starts using a substance at this age makes them very vulnerable to a phenomenon called as a gateway phenomenon, where a gateway drug is something that once a teenager is exposed to something which is easily available, like tobacco, alcohol, or marijuana, it makes them much more it makes it much more easier or much more susceptible for them to try harder drugs or more illicit drugs later on in the future. And that is what is called as gateway phenomenon. So if there is in very simple terms, there is a gateway in the brain, and if that gate is broken by some simple addiction, some simple substances like tobacco or alcohol, which are very easily available, then that breaks that gate, and then the brain becomes more vulnerable to use or abuse much more difficult or harmful substances later on in life. And that, this, like I already said, that gateway is like a metaphor, and we need to understand that if the teen gets past these gates of alcohol, marijuana, we can probably prevent use of hard drugs or more illicit drugs in the future. Of course, chronic use can cause cognitive changes later on. Now that can go to, we can think of more difficult and more long lasting effects on their life as well. So prolonged use, like Dr. Parijat said, can lead to dependence, physical symptoms. But at this vulnerable age where they are trying to study, where they're trying to make something out of themselves, they lack the focus and attention, and that can have major psychological impacts on their brain and their life. Maybe they can slip into anxiety, they can slip into depression, they can also have other psychiatric illnesses. Cannabis and alcohol is very, very well studied to have a propensity of making the person more vulnerable to schizophrenia or bipolar illnesses. So it's very important that we tackle this problem here. Otherwise, there are going to be lifelong consequences. Of course, now we see a global trend in women starting to smoke, and Parijat has already mentioned that. I won't go there. But the newer addictions is something which is the challenge right now, because these are something which is very easily available. These are e-cigarettes or vapes or battery operated devices. Now they turn heat. The heat turns the liquid into a vapor, and the liquids contain nicotine and THC or tetrahydrocannabinol, and both are addictive. So e-cigarettes they have generally entered the market very, very freely available for adults, but adolescents are finding it more and more attractive because vapes are being marketed in a way that they are lesser destructive, they are lesser, I mean, it's not as bad to vape than it is to smoke, and that's how it's been marketed. But in fact, it's the other way around, where the negative effects of e-cigarettes are different, but they're equally or probably more worse. So like regular cigarettes, they do contain nicotine, but they also have THC. They can cause severe lung injuries, and those lung injuries can be sudden and long lasting, and more so lethal. So of course, the second-hand vapor is also something which is known to cause a lot of problems. Social media is booming with the vape culture, where there are as many as 633 Instagram pages with vape or vapes in their account name itself. So even in India, there are so many. If you just type on Instagram, and teenagers are, most of them have an Instagram account these days. Even kids of lower socioeconomic strata, which you might feel, oh, do they really know what is Instagram? All of them know, and most of them have individual accounts. The parents, unfortunately, most of them are not aware what the child is doing on these Instagram accounts. So there are many kids who order these vapes online, and the parents, their Paytm or their Google Pay is linked to it, and they just order it online. Unfortunately, fortunately, the India did prohibit the sale of e-cigarettes in as long ago as 2019, but nothing is happening, because vape is so easily and so it's available anywhere. You can even go down. These days you're getting it at grocery stores also. So there are so many kids who come into Nair. We have a child psychiatry OPD, and there are as many as 3-4 children who tell us every day that yes, they vape. And they're, in fact, to the point that now schools, earlier it used to be that every time you enter a school, they would check your bag whether you have a phone. Few years ago, now they're checking whether they have vapes. It's come to that because it's so freely available. You can go to a grocery store, you can go to any other store and just ask for a vape, and it's not very expensive also. These vapes come for as low as 150-200 rupees, which an adolescent can easily procure from, one of their parent, or, get it from somewhere. So this social media, and it's on social media also, people are promoting it. Ori, I don't know if, there are people who know him, obviously, but he's a social media influencer. He was seen on stage of late, where at an award function, where he was using vape. And if we are going to promote it, it's going to be more and more difficult. In fact, there is something called as an Association of Vapers India, and it's a non-profit organization which defends the use of vape, and they are saying that vaping is much more better, and smokers have much higher health risks as compared to vapers. It's gone. So how do you understand? Obviously, the child is not going to be open and say that they are vaping or smoking to their parents or to you, but there are some behavioral signs which can probably point towards them having a nicotine or a substance abuse. Depression, having mood swings, being very irritable, anxious. Many times the parents feel that, oh, this is just, he's a teenager and he might do this or she might do this. But they can, when it becomes too obvious, maybe that's a problem. Having to difficulty focusing, difficulty staying on a task. Sometimes they become more secretive. They're locking themselves in the room, or they're, they want to go and meet a friend, to smoke. Decline in school performance, stealing, lying, because they need money to procure these cigarettes or vapes. Loss of interest in hobbies, because they're whole focus is towards trying to procure a substance. And like Dr. Parijat said, once you become addicted to it, it becomes very difficult for us to come out of it. So their whole focus is on how do I procure my next cigarette, or how do I procure. And unfortunately, maybe an adult might still have that social understanding or that judgment that, okay, I cannot probably lose work, or I cannot let my private life get affected. But for an adolescent, they don't have the capacity or the judgment to think that way. Acting aggressively and being more angry, sleeping more than usual, missing school, academic decline, missing sports, something that they would love before. These are some behavioral signs. Of course, physical signs, I'm sure you know more when it comes to their oral hygiene. But poor hygiene in general, watery or bloodshot eyes, dilated pupils, nosebleeds or runny nose, sore throats, puffy face, shaking hands, headaches, fidgetiness, tremors, sudden weight loss. These are all possible physical signs of a substance abuse, not just nicotine, but substance abuse. But if they're facing any of that, maybe that's a pointer towards a substance abuse, and it's better to get evaluated. So what are the barriers to tobacco counseling? Now, this we are talking with regards to with regards to a dental practice or to a physician, because there is not a lot of time to invest when you are obviously the patient has come to you for other things. So we face that there's a lack of time. We don't have so much time to dedicate to this. There is a lack of incentive for the patient. I mean, I am here probably for another complaint, either a dental complaint or another physical complaint, and I don't want to talk about this right now. There's a lot of resistance either from the patient or from the parents also sometimes, because the parents also don't, until and unless they know that, okay, their child is actively into a substance abuse, you might face a lot of resistance from there. We don't have a lot of patient education material in our clinics, in our general practice. And also there's a perception of poor effectiveness and a fear that giving unwanted tobacco cessation counseling may upset your patient. Sometimes we fear that, oh, I mean, if he or she has not asked for it, why do I go ahead and actually talk to him or her about it? That may upset it. So But at the same time, we need to understand that even if it might upset them for a little while, we need to work ourselves around it and maybe form a system in which how we approach these kids or these adolescents or the parents when it comes to talking about tobacco. So yes, but then yes, we do have a lack of formal training where our training doesn't help us approach for difficult problems. We even in general medical OPD, when it comes to talking about more difficult things like addictions, they will just send it to psychiatry OPD, psychiatry mein jaake pucho. So it becomes very difficult, I understand, because there's a lot of resistance which comes across. This was a very interesting survey that I was just going through some material online, and I found that this was a very interesting survey done in pediatric dental practices, and they said that there's a lot of there's low knowledge about general adolescent tobacco use, but the pediatric dentists were held very high positive attitudes towards intervening. So they were all up for it, but they didn't know how to do it. The common barriers that they faced was that they said that we don't know how to approach that topic, and we don't know what exactly to say to these patients for counseling. So why are we collaborating? Because I feel that dentists are ideally positioned to counsel about the adverse effects of tobacco products. They can really make a huge difference in the way we tackle this problem. So maybe dental practitioners can integrate tobacco use and prevention cessation services into their routine daily practice. I understand that it's a very big, very, very vague thing to say, but we can start with simple things. Dentists are obviously usually very concerned about the adverse effects of tobacco in the oropharyngeal areas. They have easy access to youth and caregivers, which other physicians don't probably. They have that bonding with the patient and the family that they can use that to influence the patient in integrating education and interventional methods into their practice. And you can build the patient's interest in discontinuing tobacco. So what can we do? Simple things. If of course, if you feel that you need to refer a patient to a psychiatrist or a psychologist, you can do that, but we can probably start with simple basic things like asking the patient about their smoking status. Ask every patient about their smoking, all adolescents or all of them who come to your clinic, ask them, but don't probe them or don't push them. Some of them might need time to trust you. So give them that time. Maybe after they have seen you for 3 or 4 times, you can probably, ask them in confidence, and privacy always should be maintained. Do not ask them in front of their parent or whoever has come with them, because they will just not open up then. Assess how bad the situation is. If you feel that they are really, being very addicted, there's a lot of substances that they're doing, or they're doing in the frequency is a lot, probably it's best to refer them to someone who is dealing with addictions. KEM Hospital, Parijat again. But dentists should advise the smokers to start about quitting at nearly every encounter that they can have, because only we need to keep on trying. There will be a point where that message might go through, and maybe maybe that patient or that person might start considering, even if we get them to consider seeking help. Even that's a very big challenge that we have probably done with. So we call it pre-contemplation. So there are stages of motivation when a person is trying to quit a substance. So usually people are in pre-contemplation mode, that they are not even contemplating whether I should stop this or not, whether this is a problem or not. So even if we try and push them into the next stage, which is the contemplation phase, where they at least understand that, okay, this is a problem and I would maybe need to do something about it. Kab karenge, kaise karenge might not be important right now, but even if we push them from pre-contemplation to contemplation, that's a huge step for them, for us as well. So assist them by providing information on support options on nicotine replacement therapy. Our next speaker is going to talk all about it. But give them the options, even if they are not ready to quit right now. Just tell them that, okay, I just want to give you some information. So maybe you don't want to go ahead with it. Ask for, arrange a follow-up for that. Every time probably you arrange a follow-up for your dental checkup, also have a follow-up for this. And maybe those follow-ups might not be as frequent as your dental follow-ups, because again, when there are children and adolescents, they don't want to be pushed into doing things. So give them a little bit of time to think about it. What can you do in your clinic? A simple chart system to to document, like you document all of your other things. Maybe you can also document their tobacco use in their files. Inclusion of, maybe in your clinic, you can have a local referral source for tobacco cessation or nicotine cessation, some telephone numbers or some numbers which they can easily access. There are a lot of guidelines for cessation counseling. We can help you with that. Give them information on appropriate pharmaceutical products which are available. Even if they don't want to quit, again, even if they don't want to quit, just give them the information. Maybe it might penetrate someday. And always keep the parents in confidence. When you are doing all of this with the child, we don't need to kind of bombard the parents with that information that, oh, your child is smoking or doing something. But we can keep the parents in confidence, and this, I am just trying to give your child information about it, just because you can say that this is just something that we do for all children and adolescents in our practice. That way the parents are also not really worried. You maintain the privacy of your child, of your adolescent patient also, and you get the job done. Some brief intervention that you can do probably at your clinic, if at all the child is not or the adolescent is not willing to go anywhere. Ask simple questions, assess their willingness to make a quitting attempt, urge in a clear, strong, but non-judgmental way. Maybe sometimes they do want to do it, but they find it difficult. Help them with a quit date. And you can probably follow up on that with every session that you have for your follow-up, for your dental follow-up. Motivating factors for adolescents, it might not be that you might get a heart attack someday. They might not find that a motivating factor, but they may find things like physical attractiveness, dental concerns, aesthetics as more important motivating factors. So if we do try to involve that information in our counseling, that, oh, this is going to affect your the way you look, then probably it might help us in motivating them more. Something that we have observed, especially in boys, is that they are really, when we tried counseling them with regards to their sexual health also, they were more interested in understanding how substance abuse can affect their sexual health. And then they were more motivated towards probably trying to make an attempt to stop smoking or any other substance. Our role is to educate, to monitor, to support them, and also maybe show them that if, like Dr. Parijat said, if there are people in the audience who also are struggling with that, show them that we have also done it, and then maybe that can be the bigger motivation factor for them. The adolescent brain, yes, it is at a risk. It does seek risks. It's primed, for taking those risks, but it's also primed for learning. So let's work towards that. Let's work together as dentists and psychiatrists and physicians, all of us, because it's a very pertinent health problem that we are facing right now. The numbers are just exponentially going up, and on this World No Tobacco Day, I think that would really be nice that we join hands and work towards it. These are few helpline numbers for, especially for children and adolescents, who can, if they're struggling with addiction or from any other problem, psychological or psychiatric issue, they can approach these numbers, and they'll be taken care of. Of course, in our hospital, we have a specialized child and adolescent psychiatry OPD. If they want to approach us, that's also fine. If they want to get in touch with me, yep, I'll be more than happy to help. Thank you so much. I think I overshot time, but I'm sorry about that.
Thank you, Dr. Prajakta, for quite an enlightening one. Vaping, thank you for touching base on that. Quite a lot of people know vaping is bad. Smoking is equally bad. Vaping is probably worse. And thank you for shedding light on that. And thank you for making us realize how adolescent counseling is same, but different. Thank you for that. Which brings us to our third speaker. After all the mental work, let's do the dental work. So our next speaker for the day is Dr. Akshay Ranade. Akshay Ranade sir is a dear friend, very much a part of IDA Thane. He is by vocation an MDS, an oral maxillofacial oncologist, holds a PG diploma in implantology from the University of Lille in France. He is a fellow of the clinical research from UK, a global anti-tobacco leader, a fellow from the Johns Hopkins University and the Bloomberg Foundation. And he is going to talk today about the pharmacological management of tobacco cessation, which works synergistically with what the other two speakers today have spoken about, the behavioral management and the pharmacological management. I hand it over to Dr. Akshay. All yours, sir. Take it ahead. Dr. Akshay, are you there, sir?
I am making Akshay, I'm giving him the speaker rights.
Sir.
Akshay, you can start with your presentation. Akshay, you're not audible. Not audible. If the volume is enough, mic is on. Increase. Now you speak. Given you the speaker rights. I'm just removing you as a speaker once, and again I'm making you a speaker. Okay. You can start again. Your screen. Yeah.
Yeah, I'm just sharing the screen.
Yeah. Share entire screen.
Is it fine?
Yeah, perfect now. Just click
Yeah.
on hide in that small banner. Click on
Yeah,
hide.
just yeah. Is
Yeah,
it okay?
Yeah, perfect. You can start now.
Yeah. Well, we have a lot of electronic glitches. I mean, I think so. Those are easy to, they are difficult to surpass as compared to the addiction. At the outset, I would like to express my heartfelt gratitude to IDA, Thane, and IDA as a whole, HOI being a part of IDA HO also, because we run 2-day courses for tobacco de-addiction, tobacco cessation programs. I would also like to extend my heartfelt gratitude to Dr. Shobha Nair, Madam, from the Bombay Psychiatric Society, Dr. Manisha Lad, Madam, who is the president for our Thane IDA branch, Dr. Raj, who is my dear friend, Dr. Rajiv, another my dearest friend. On that note, I would also like to express my thanks and gratitude to the previous two speakers, Dr. Parijat and Dr. Prajakta. A beautifully curated presentations they had dished out, and especially as regards to the behavioral counseling, which is the main pillar in any addiction therapy. So moving on to my presentation, the topic here is about pharmacotherapy. Generally, people tend to jump onto this pharmacotherapy without understanding the basic underlying or rather the underbelly of how important behavioral counseling is in regards to tobacco cessation. As what Mark Twain has rightly put in, quitting smoking is very easy, and I have done it hundreds of times. So it's the relapse, the withdrawals, the cravings, which are very important to be treated, apart from the main addiction per se. So moving on to the WHO Empower, this is an acronym given by the WHO people. So this is a set of 6 cost-effective, high-impact measures developed by WHO to help countries to reduce the tobacco demand. This is also being monitored by the FCTC, that is the Framework Convention on Tobacco Control. We have 181 countries who are member states for this FCTC, and mind you, USA is out of this FCTC. I don't know how and why, but USA funds this anti-tobacco campaign to the maximum in the world, globally around, but it is out of this FCTC. So where do we stand? As what Dr. Prajakta has rightly mentioned, that dentists or the medical professions, we are there to offer this particular O component, that is offer to help to quit tobacco use. And thus we are going to create a dental task force, because by implementing these measures, countries can effectively reduce tobacco use and its associated health consequences. The Empower framework provides a structured approach to tobacco control, enabling the countries to assess their progress in implementing the WHO framework FCTC. Now, we as dentists or clinicians cannot possibly touch upon these vectors of MPWER, because these are something as regards to the institutional programs or their organization-based programs, and we don't have the reach to, we don't have the power, we don't have the reach to govern all these things, because we are only into private practice, a clinical practice, or a group practice. So in what best way we can offer help as far as the tobacco cessation is concerned is to help the people or the patients or the clients. I call them all clients because we run a proper tobacco cessation clinic apart from doing a routine clinical dentistry. So we call them as clients. We don't address them as patients because we need to have a good rapport with them. So when actually does a doctor or a physician or a dentist would like to start a pharmacotherapy? Okay. So before moving on to the actual therapeutic use of the pharmacological agents, I would like to stress the importance of behavioral counseling, which Dr. Prajakta has rightly mentioned. According to first, once the client comes to you, you have to take a detailed case history format. This case history format I have pinned onto your chat box. You can go through that after the session is over. It is a 4-page one, out of which the second page is the Fagerstrom's analysis, beautifully developed by Carl Fagerstrom way back in 1979, modified in 1991. And in that you have a smoked chart and a smokeless chart. So when a patient comes to you for de-addiction, you never know, he might be smoking, he might be consuming raw tobacco, he might be consuming gutka, Thane, whatever. He might also be hooked on to some substance abuse. He might also be hooked on to some drug dependence like cocaine or any other artificial drug. So how are you going to classify this particular client? So you need to have an addiction scale for the smokers and for the smokeless. And accordingly, your pharmacotherapy, the entire domain of pharmacotherapy will be governed by the scores which are being evaluated in this case history analysis. So this case history analysis is a very detailed one. And we have tried to, bring in all the references and try to create a one which can be easily used in your dental clinics. Or even as for example, in any medical clinic, he might be a physician, a psychiatrist, a psychological counselor. So in that, once you score a particular patient, see, since we have very less time and I have to, actually bonsai my presentation into this 45 minutes. So I'm just, going through it at a pretty faster rate. But in case you have any detailed queries or you want to ask a particular question, you can always get back to me later on. So what we need to do is, first we need to address the issue of NRT versus non-NRT. So NRT is nicotine replacement therapy and non-NRT is the drugs, okay, the medication therapy. So whether the combination therapy can work for a particular patient, or whether we have to only do away with behavioral counseling, or we need to combine. So it is BT with NRT or BT with non-NRT or BT with both NRT and non-NRT. So BT means behavioral therapy. Then we have to also look into the cost effectiveness, because these drugs, what Dr. Parijat rightly mentioned, he said that he will be giving away those drugs free of cost, but that is not the scenario in private practice. So these patients have to buy all these drugs. So that's the reason why I said it has to be a dental task force. So for a patient, the nearest de-addiction center has to be very, very close to his place, so that he doesn't, because people are in these de-addiction things, they tend to procrastinate a lot. So basically they have to approach the nearest de-addiction center. Now we also have to look into special conditions like elderly population, pregnant females, psychotic disorders, and any specific precautions if the non-NRT drugs, the allergies as regards to non-NRT drugs are concerned. So to know what we know is what we know, and to know what we do not know is what we do not know. That's true knowledge, isn't it? Well, that keeps people like you, me, and this fellow thinking, because this tobacco de-addiction scenario is a vast domain. So we do not know how to plunge into it, because most of the times we have to obey the off-label uses of all these antidepressant drugs. Now, when we talk about pharmacotherapy, we are lost in dark. We do not know from where to begin. So I can just sum it up like as what Dr. Parijat has expressed his views on psycho, socio, and biological factors governing the tobacco de-addiction. Dr. Prajakta has also mentioned rightly about the 5 A's, and I think so she missed the 5 D's or the 3 D's ka slide. So once you do a behavioral counseling, you do a case history analysis, start with a quit date. Okay, assign a quit date. Once you assign a quit date, according to your Fagerstrom's analysis, you will have to patch the patient into those categories, or rather fit him into those categories, which are once you start doing a particular case, you will understand that you can classify your clientele. Once you classify them into contemplative, pre-contemplative, contemplative, action phase, maintenance phase, then you have to start. So you have to pick only those patients or those clients who are into your contemplative stage. Okay, if you take a patient right from his pre-contemplative stage, you cannot possibly, bring him like a Eid ka bakra. So never do that. First, let him understand. He should know what kind of problem he faces with. So that's the area from where you can take him, because the journey has to be very easy for him and as well as for you. You cannot just force anything upon anybody. So there will be a lot of attrition. When you start doing all these cases, when you start treating the cases, you will have a lot of attrition rate. And supposing you examine or you assess 100 patients, patients might actually, end up with tobacco cessation or de-addiction. But it is fair enough. I mean, 5 out of 100 is also fair enough as far as the Indian population or the Indian tobacco population is concerned. So tobacco cessation has a 3-pronged approach. You have non-pharmacological, that is behavioral therapy, tapering, cold turkey. Cold turkey means it is like switch in and switch off. So you tell, this happens generally in those low socioeconomic strata wherein they believe in some Aniruddha Baba, and then there's Aniruddha Baba says that you have to stop smoking, and they stop smoking. Okay, that is it. So then comes the pharmacological component, and then comes the newer advancement. So in pharmacological component, you have the nicotine replacement therapy, the transdermal nicotine patches, the drugs, which are the non-NRTs. So therein you don't give nicotine, you give them drugs. And the MAOA inhibitors, that is the monoamine oxidase inhibitors. So ICD, International Classification of Diseases. So tobacco use, harmful use, dependence, is actually nowadays classified into a disease entity. So this is a proper disease entity. It is not just a gray area wherein you also try to grope in the dark and you don't find, like, for example, I can to relate to my dental friends or fraternity. Generally, you come across a patient with an ulcer and you empirically prescribe him some smiley gel, okay, without even understanding what kind of ulcer that is. So that is an empirical therapy. Here, you are classifying it as a disease entity, and now you know what kind of pharmacotherapy you will have to use for a particular patient. So what is so unique about nicotine use and addiction, as what Dr. Roy has mentioned in his presentation, that it is a behavioral disturbance. There is no behavioral disturbance of this intoxication, because the patient is not going to lie in a gutter, like unlike alcohol abuse. Okay, there's no damage to others in society. It is considered as legitimate and legalized. Okay, and can be commonly viewed as, okay, it is within my control and I can stop it anytime whenever I want, and I don't require any external help. But remember, this is the most addictive substance to ever known to the mankind. Now, Dr. Raj had requested me that day to present few pictures for the medical fraternity in general, because today we have a mixed crowd for this webinar, that is the dental professionals and the non-dental, the medical professionals. So they wanted to check whether, because they do not every time ask the patient to open the mouth. And as what Dr. Prajakta rightly mentioned, we as dentists are ideally positioned. I like the word ideally positioned. So because we can look into their oral cavity. But believe me, whatever is the stage of the patient orally, as regards to the signs, what we see, it has no correlation with the addiction, because addiction is a psychological derivative. It is a physiological derivative. These particular lesions have to do with the therapeutic use. So they might be precancerous lesions, like you have leukoplakia, speckled leukoplakia, erythroplakia. Then moving on to conditions, you have the oral lichen planus, the OSMF, the submucous fibrosis, the discoid lupus erythematosus. So this has no correlation with addiction per se. So I wouldn't advise anybody to see and check the severity of oral lesion and then try to correlate with the addiction. Okay, so actually there is no correlation. So let us stick to what happens when the nicotine goes into the brain, as what Dr. Parijat has rightly mentioned. So basically nicotine it will cross the blood-brain barrier in 15 to 20 seconds after the smoke and in 30 minutes after a smokeless tobacco. So after 15 to 20 seconds, it will cross the brain, it will go to the lungs through that capillaries, it will go to the blood-brain barrier, cross that, reach the ventral tegmental area, nucleus accumbens, release dopamine, okay, by combining with the alpha-4 beta-2 receptors. This is already being covered, so I'm just going to rush through the slides. So as we have the nicotine side effects, we do have nicotine withdrawal symptoms, as it has been rightly elaborated by, I think so, Dr. Prajakta madam also. So what is most important is the withdrawal. Now, if you see this graph, your severity of withdrawal symptoms starts, it peaks in the second week, okay, and then it gradually tapers down and then it plateaus. Then there is increase in appetite and weight gain, and then the craving starts. So craving will follow your weight gain, but it will last longer. So at what stage you would like to introduce your pharmacotherapy is very, very important. And at what stage you would like to start your behavioral counseling is also very important. How to pin a quit date, that is also important. So as you move on, as you jump onto this bandwagon of treating the patients or the clients for their addiction potential, you will realize that for certain section or a cult of patients, you need to assign a quit date too early. For a certain section of people, you might assign a quit date later on and start the pharmacological drugs at a much earlier stage. So treatment modalities, basically they are grouped into 4. Only behavioral counseling coupled with nicotine replacement therapy, behavioral counseling coupled with non-nicotine replacement therapy or the medication, and behavioral counseling coupled with NRT and non-NRT. So the current targets for any drug therapy include relapse prevention, withdrawal, the basic quitting, harm reduction, nicotine maintenance, and smoking reduction. So in day 2 scenario is that in nowadays it's like 33% of smokers manage to quit, but overall in a period of 1 year it is only this 33% comes down to drastically to 3 to 5%. So it is only the 3 to 5% people who are actually going to remain abstinent. Okay, it might be because of their willpower, it might be an assisted approach, it might be that they have approached a tobacco cessation clinic, whatever is the reason. So these are the approved drugs. My fellow dental colleagues can take pictures of this, because this is the sum and substance of what all things you will be prescribing. There is always one pertinent question which I am asked during my presentations or the 2-day workshop what we conduct at IDAHO. And I would like to also thank here Dr. Shobha Nair madam for mentioning that collective approach. This collaboration has to be done between dentist and the psychiatry, the medical fraternity, like your fraternity, because we want people like you on board to help us, teach us about the behavioral counseling aspect. Because in those 2 days, we also do role plays. We have a crowd of at least 40 people, dentists, who attend this seminar or workshop, and then we divide them into 10 group, and then we give them a scenario. So each case, and then they enact that particular scenario, and that is how one person will become a counselor, one person will become a psychiatrist, one person is a dentist, one is a victim. So then accordingly they start realizing like how do you go about solving a particular case. So coming back to drugs, this is the first line FDA approved drugs, that is the bupropion SR. Then the NRTs, in that you have patch, the TNS, the gum, inhaler, lozenges, and nasal spray, and the varenicline. The second line is the clonidine and nortriptyline, and the others are the selegiline, moclobemide, MAOA inhibitors. So now out of this, dentists are allowed to prescribe the first line and the second line, no doubt about it. Only thing is these clonidine and nortriptyline are the drugs which have to be used for their off-label uses. Okay, they are not supposed to be prescribed by the dentist for their labeled uses. Labeled means they are basically tricyclic antidepressant. This nortriptyline is a TCA. Clonidine is a centrally acting adrenergic agonist. So they cannot be prescribed for the neural disorders, but they can be prescribed for your tobacco cessation. Now, what are the types of nicotine replacement therapies? These are the patches. Then you have the gums, the lozenges, sprays and inhalers, and pastilles, according to the US FDA. Now, Indian FDA, they have approved the patches, the gums, and the pastilles. The lozenges and sprays and inhalers are yet to hit the Indian shores. So these, I have purposely put the photos. I mean, I could have mentioned a disclaimer also, but for the people to know what all products are available, I have not darkened their faces. So now we have to do a little bit of math, because as I had shown you the Fagerstrom's chart. Dr. Raj, please remind me if I overshoot my time, because this is a pretty long presentation. I'll have to be a bit faster. So this is a normal size, doctor. Then this is a king size. You have a super slim. These are the Virginia slims. You have super king size. Now, our previous speakers had also mentioned about the size of the cigarette, because every ml or every millimeter of that cigarette counts. So one cigarette contains 10 to 12 milligrams of nicotine. Body will absorb only 1 to 2 milligrams of nicotine per that 10 to 12 milligrams of nicotine. So you have 10 cigarettes giving 10 to 20 milligrams of nicotine. Now, coming to the smokeless form, 1 can of khaini or gutka, that is 1 pan parak ka dabba, will have 144 milligrams of nicotine. 1 ubiquitous sachet, that is the small sachet, which generally people use it for khaini and gutka, contains 10 milligrams of nicotine. Body will absorb. So accordingly, if you convert them into the cigarette form.
Ye chodo, ye jodo. I love the bird. Reel making.
Hello. So body will absorb 60 to 120 milligrams of nicotine from a can. Now this, as regards to the sachet, the same body will absorb around 10 to 20 milligrams of nicotine from a sachet. Now, nicotine from smoke takes 10 to 15 seconds to cross the BBB, that is the blood-brain barrier. But for the smokeless form, it is going to take 30 minutes, because here in smoked form, it directly goes to the lungs. There is no first pass metabolism. In the smokeless form, it is going to go through your oral cavity, through your sublingual route, as what you would do for your nitroglycerin. Then it will get absorbed and adsorbed through the oral mucosa. Through the non-keratinized oral mucosa, it will go to your gut, it will go to your liver, it will go to your portal system, hepatic system, portal system, enter the circulation, and then go to the brain. So it will take around 30 minutes. So now for a person who is only hooked on to gutka, that is chewable form, it might be gaicha, gutka, whatever, rajnigandha, whatever. Now 30 minutes is the time. So now you need to remember that your first pharmacological agent or your NRT has to start within that 30 minutes. Okay. Whereas for this nicotine, this 10 to 15 seconds is a very limited window. So we don't have those sprays or inhalers, because inhalers are going to actually mimic as a nicotine release as what a cigarette would give you. So coming to this particular chart, this is very important, and Dr. Prajakta has nicely stressed the those harmful effects of vaping. We have nowadays vaping, fishing, juuling, and it is per millimeter. Mind you, it is per millimeter. Cigarette was far more better, I would say. I mean, I'm not trying to endorse cigarette. But if you look at hookah, this is now 1.04 milligrams per puff. And for cigarettes or cigars, it is like 13.3 to 15.4 milligrams for large whole cigar. Now, if you see this hookah comes in a quantity of around 50 ml. Okay, if you go to a shisha hookah or any hookah bar, you have a 50 ml. They say that you have water in that, but it is all bullshit. So once you have that inhalation, it is 1.04 milligrams of nicotine for every one puff. So now 50 ml is going to give you at least 200 puffs. So now imagine the amount of nicotine which is going through hookah. Okay, and then they say that they are very naive in saying that hookah is very is harmless. Okay, so it is not so. Same is the case with this particular, juuling or fishing, because it comes as a millimeter tag. Now coming to nicotine gum, you can take down this chart because this is very, concise form. In a concise format, I have tried to deliver all this. So it comes as 2 milligrams or 4 milligrams. Why 2 milligrams? Because out of 2, only 1 milligram is going to get absorbed, and out of 4, only 2 milligrams is going to get absorbed. Now, how do you use this? It has to be chew and park. So you chew on one side, park on the other vestibule. You chew on the other side, park in another vestibule. So dosing is, if it is a Fagerstrom's analysis for a smoked tobacco, less than 15 cigarettes, greater than 15 cigarettes. You always try to correlate with that analysis, okay, the case history analysis. Now for less than 15 cigarettes, start with 2 milligram dose. For greater than 15 cigarettes, start with 4 milligram dose, because your bioavailability is only going to be 1 milligram or 2 milligrams. Now you can have a fixed dose or a scheduled dose, or you can also have a as needed dose. So if you are hooked on to 25 or more cigarettes per day, then if you smoke within 30 minutes of waking up, these are all the questions which are included in those analysis, the Fagerstrom scale. So accordingly, you will have to chew and park the particular gum, and accordingly, you will have to start with that particular dosage. Now, if you are going to treat a smokeless tobacco user with a nicotine gum therapy, then if the first dip of the day is less than 30 minutes after waking up, then or if he is using greater than 2 cans or pouches of tobacco per week, then you will have to straight away start with 4 milligram nicotine gum. And if that is greater than 30 minutes after waking up, then you might start with 2 milligrams of nicotine gum. Now, as you move on, you can have maximum of 10 to 12 pieces. Now, see, now for example, 10 means 40 to around 48 milligrams of nicotine per day for that less than 30 minutes. And here it will be around 20 to 24 pieces per day. So now these are the side effects of gum, because gum is very obnoxious in taste. I myself have tasted it. So I just wanted to know how the gum which I am going to prescribe it to the patient, whether he will like it or not. But believe me, nowadays there is a tsunami of patients who are coming back to me saying that we have lost the taste of cigarette, but now we are hooked onto the gum. So there is a side effect to this nicotine replacement therapy. Like people leave cigarette or the chewable tobacco and they get hooked on, they get addicted to your gum, because both are nicotine. One is a nicotine replacement therapy and one is a nicotine from the cigarette or the smokeless tobacco. Now, these are the side effects. One basic thing is racing heartbeat, then jaw discomfort because you are constantly eating on both the sides, and there is a sore throat. Now, nicotine lozenge. You do get nicotine lozenge in India. So again, it is available as 4 milligrams or 2 milligrams. Again, you will have to classify according to your Fagerstrom's analysis. Allow it to dissolve. Here, you do not have to go ahead with the chew and park mechanism. It is just to be kept into one vestibule, and you have to suck and chew. So it is like it's like a sweet or a toffee what you would like to place in your vestibule. Then you have nicotine inhaler. This, if it is introduced, if it hits the Indian markets, then it would be a great this thing, because of the fact that it will exactly mimic the smoking scenario, because it will also reach the blood-brain barrier within 10 to 15 seconds. But unfortunately, in India, we don't have this inhaler as on today. Then you have nasal spray. That also, you can take down the photos, but this is also not available. So I'm not going into the details of it. Coming to transdermal nicotine patch, this is my favorite because I have been using it. The most common reason, or the rather important reason for me prescribing this is because patient will try to look at this patch in a way that he has a sense of, controlling the tobacco addiction, because there is nothing in his mouth, but yet he has the willpower, or he has that sense of assurance that I can control my nicotine addiction. Okay, because this patch is attached to the skin. Nothing is given orally. So this patches gives a major dose of nicotine through the skin. It comes in three strengths: 7 milligrams, 14, and 21. So patches are weaned off nicotine by switching to lower dose patches over a course of weeks. Now again, here you will have to classify. If the patient is hooked on to 10 cigarettes a day, you can start with more than 10 cigarettes, you can start with 21 milligram dose. Now coming to use of nicotine patch in the smokeless tobacco, if a patient is hooked on to greater than 3 cans or pouches of tobacco per week, then you will have to start with 42 milligram patches. So 21 into 2. So 21 milligram one patch, combine it with another 21 milligram. If he is 2 to 3 cans of pouches of tobacco per week, start with 21 milligram patch. If he is less than 2 cans or pouches of tobacco per week. Now, just remember one thing here. All these studies were done in US. Now in US, you always have cans and pouches. Here and there, they don't have the actual chewable form, but they supply this chewable form in the form of a snuff. Okay, there you have a lot of snuff gummies also. Like now in Canada, you have those cocaine gummies, or I think so, marijuana gummies. So here, there they have, so the studies had enrolled the cans and pouches. But to relate to the Indian scenario, now this one can be related to say around 50 sachets of Rajnigandha, or one pouch can correlate with 25 sachets of Rajnigandha. Okay, so you'll have to do the math in that way. You have a 16-hour patch or a 24-hour patch, depending on the permeability of that membrane. It's like you stick onto your skin like a continuous glucose monitoring device. Okay, so it's just stuck, and through the semi-permeable membrane, the nicotine it leaches out, and then it gets absorbed onto the skin, and then it gets absorbed. So now there are side effects to this also. So the side effects depend on the dose of nicotine, the brand of the patch, skin characteristics and allergies, and how long the patch is used and in what way it is applied. So you might have skin irritation, there is dizziness, there is racing heartbeat, there are sleep problems, there is muscle ache, there is nausea, headache. Sometimes even people tend to vomit initially. But this will last for a week or so, and then it will taper down. Now, this is a graph which shows how your cigarette, the plasma nicotine levels after a cigarette as compared to the plasma nicotine levels after different types of NRTs. So you have the magenta color, or that pink color is the patch, then you have the yellow color is the gum, and cyan blue color is your nasal spray. So your nasal spray exactly mimics your cigarette levels, the plasma nicotine levels after the cigarette. So if you have an inhaler or a spray, that is the best thing. But the best one is a patch, because patch is going to have a slow rise and then it will plateau. Gum will also have a rise and then it will plateau, but it will decline later on, because gum will go through your first pass metabolism, that is through your portal circulation, hepatic circulation, and it will take time to reach the brain, to reach the nicotinic receptors. Now, NRT patches are option 1 is 20 or more cigarettes per day. So this is the guideline what they have mentioned, 21 milligrams, 1 patch per day for 4 weeks, and so on. Now, option B is less than 20 cigarettes per day. This is the NRT patch therapy for the smoked form. So 14 milligrams, 7 milligrams, 7 milligrams. Now, this is that transdermal delivery mechanism. It comes with a medicinal reservoir outer covering, and then there is a diffusion membrane. So there is an adhesive layer, and through which it diffuses out. So these are the areas where on the body where you need to attach the pouch, the side of the shoulder, or the front where you could, the front just below the scapula blade, or at the back on the top or at the bottom. Okay. It has to be clean skin. There should be no hair, and there has to be no signs of any inflammation or no skin lesion. So, and advantages are it avoids gastrointestinal tract totally, avoids the first pass metabolism. Then it has improved patient compliance. There is extended activity and less chances of over or underdosing, because it is the slow release of that nicotine which goes through your skin. The most important point is that these patches have a higher efficacy, because they work according to sustained release technology over a period of 24 hours. There are less amount of morning cravings, patient compliance is higher, discrete amount of dosage forms, and it is very easy to use. and the person does not need to engage in timely reminders of dosage. So it's like throughout the day after he wakes up, you just after your bath or something, you just attach that patch and he's good to go for the entire day. So what is the difference between, there are three reasons why treatments that work for cigarette use do not always work for smokeless tobacco. One is a normal dip or chew will give body 3.6 to 4.5 milligrams of nicotine, whereas a cigarette will give body 1.8 milligrams of nicotine. Secondly, when an individual takes a drag from a cigarette, it takes 10 to 15 seconds. But here, so this provides a quick satisfaction to their craving. But with a smokeless tobacco, once a dip or chew is placed into mouth, it takes nearly 30 minutes. And the third most important point is when a cigarette is extinguished, the individual is no longer receiving nicotine. Whereas in case of a smokeless tobacco, this particular nicotine absorption continues for another 1 hour, even after the tobacco is removed. Okay, even after the tobacco is thrown off. So in general, we have classified the pharmacotherapy for smoked tobacco. You'll have to use behavioral therapy along with the non-NRTs. And for smokeless tobacco, you'll have to use behavioral therapy with NRTs. Okay, you can combine NRT for smoked also. That is not a thing, but this is what we have generally observed. Now, moving on to the non-NRT therapies, you have this particular drug, which is a bupropion, which is an atypical antidepressant drug with reuptake inhibition. So it comes in a strength of sustained release 150 milligrams. So for this, increase, you start with 150 milligrams per day, increase by day 3 or 4 to 150 milligram twice a day, then set up a quit date, which has to be 7 to 14 days after starting Bupron, then continue for 7 to 12 weeks, okay? And then go on with the maintenance phase. This can be used in combination with patch. It works much more better if it is used in combination with patch. The second drug is the Varenicline, which is marketed by the name, by the way, the market name for Bupron is Zyban also, which is marketed by the Zydus Pharmaceutical. For Varenicline, it is Champix by Pfizer or Chantic by, I think so, I've forgotten the company's name. Now, this is a partial agonist. It is also a natural tobacco substitute. It is a partial agonist of alpha-4 beta-2 nicotinic receptors. Now, I don't know whether we remember the pharmacology lectures in dentistry, but there is something called partial agonist, means it will compete with the nicotine molecule for the alpha-4 beta-2 receptors. So it will go and sit onto those receptors and it will avoid the nicotine to jump onto the receptors. So this is, I'm just moving a bit faster. Now this is the nicotine molecule. These, the yellow and the brown one is the alpha-4 beta-2 receptor. This is the nucleus accumbens area, ventral tegmental area, where the nicotine is going to get absorbed onto the receptor. Now, what does Varenicline molecule do? I'm just going to play it like a flashbook. Okay, so Varenicline molecule will come and it will inhibit the uptake of nicotine molecule onto the receptor. Just see this. It won't allow the nicotine to go there. So this is the partial agonistic action, and which has a maximum effect. So now this Varenicline drug can be used for cravings and for withdrawal relief. Why? Because as what Dr. Roy had rightly mentioned, what is important is addiction is it's one game. Okay, and preventing the cravings and managing the withdrawals is another game. So we need to also address this, wherein this particular Varenicline will play a very important and pivotal role. So addiction you can manage with NRTs, but for this craving and withdrawal, you will have to use a Varenicline. It comes as a starter pack and a continuation pack. This is generally the tablet form, which comes in a alu packing, and so you have days 1 to 3, 4 to 7, 8 to 14, and 15 days. So this also has to be started post quit date, or this is generally meant for cravings. So you'll have to start post quit date. Whereas Bupron can be started pre-quit date and can be continued along with a patch or an NRT. So you have the efficacy, as far as efficacy is concerned, more than double the chance of quitting at 6 months. Now these are the monoamine oxidase inhibitors. You have selegiline and moclobemide. In that, you have selegiline as tablet form and selegiline as TNS. This is the EMSAN patch. This is the only antidepressant available in a patch system. Not coming to the third line, that is the nortriptyline. Main mode of action is through reduction of post-sedation depression. Nortriptyline, this is an off-label use of this particular drug. Otherwise, this is used as a as a pain suppressor or an tricyclic antidepressant. The clonidine is as I told you, centrally acting adrenergic agonist. This also can be used in this particular dosage, that is 0.2 to 0.54 milligrams per day. Now, the newer advances in nicotine is the nicotine vaccines, where the clinical trials are already on in UK, this will sensitize the body, and the vaccine will produce antibodies to nicotine. These antibodies attach to nicotine molecules, doubling the size, and thus they won't allow them to enter the receptors. So this is as far as the another therapy which was ongoing. The research was regarding the rimonabant therapy, but it is nowadays banned because of its cannabinoid reactions. So now, choice of medications, to sum it up, depends on your adverse effects, medical contraindications, the psychology, the physiological well-being of a patient, psychiatric morbidity, cost, patient preference, and comfort. So these are the cases which we have treated up till now since 2003. After I jumped on this journey of tobacco cessation. So total number is around 2525, out of which we had a lot of attrition. Relapse was 101. But overall, I would say that journey was very fulfilling for us, because at least we could contribute to the society. Now, this was with NRTs. Now, this is solely with the patch, because patch came in, Rusan started marketing the patch since 2014. So this was with patch, you can see the success rate is much more better. So the key takeaway points is NRT or non-NRT, both are effective for reducing craving, relapses, abstinence, increasing the quit rates. Nicotine transdermal patches are the most effective. But again, I'm telling you, pharmacotherapy is not a magic bullet. It has to be coupled with behavioral counseling therapy and all other parameters, as what Dr. Parijat and Dr. Prajakta had mentioned as regards to the teenager psychology and the adult psychology. You'll have to consider that. First, classify those patients, then take them through the journey of pharmacotherapy. So I would once again thank from the bottom of my Purkinje Fibers team, BPS and IDA. These are my contact details. If anybody in the audience would like to raise any queries, I don't know whether we have a Q&A session, but yes, definitely you can call me, or you can email me, and I would be more than happy to help you out as regards pharmacotherapy, behavioral counseling. But yes, for counseling, I mean, I think so stalwarts like Dr. Prajakta and Dr. Roy, they are the main masters of that. Thank you so much. Thank you once again, Dr. Rajiv also and ICPA also for being the supporting partners for this particular webinar. Thank you so much.
Thank you, Dr. Anade. Akshay sir, quite a plethora of drugs, too many drugs to remember. I'm sure a lot of people in the audience will agree with me. And we will definitely be in touch with you if we don't remember any of the names. So yes, thank you so much. Before we go on to the Q&A, I would request our IDA Thane President, Dr. Manisha Lad Madam, to deliver the closing remarks, after which we have a number of questions. I would advise the audience to hear it out, to hear our experts today answer these questions, and then we can conclude the meeting today. Over to Dr. Manisha Madam.
Good afternoon, everyone. I'm glad that you all have been a part of this significant event organized by IDEA Thane branch in collaboration with Bombay Psychiatric Society. Thanks to Dr. Shobha Nair ma'am and her team at BPS. Tobacco use remains one of the leading causes of preventable diseases and premature deaths globally. As healthcare professionals, we have a very crucial role to play in addressing this issue. Our aim today was to empower individuals with knowledge, resources, and support to help them quit tobacco and embrace a healthier lifestyle choice. We had experts in the field of dentistry, Dr. Akshay Ranade, and in the field of psychiatry, Dr. Parishat and Dr. Prajakta, who shared their valuable insights into the health consequences of tobacco and successful strategies for cessation. We hope these discussions would help us to support others in their journey to quit. So let us all pledge on this World No Tobacco Day to work together towards a tobacco-free future. I now hand it over to Dr. Raj.
Thank you. Thank you, Dr. Manisha ma'am, for the closing remarks. We begin with the Q&A now. Our first question is directed towards Dr. Parijat. Sir, the question is, are the psychogenic substances in gutka different than tobacco? If yes, then how?
Oh, so am I audible?
Sir.
Yes, Dr. Lekhe. So basically, the psychoactive substance is the same, nicotine, be it in tobacco, what we call as tambaku in our native language, and gutka. The difference is in gutka, apart from nicotine, they also contain certain additives like lime, slaked lime, like catechu, like areca nut. And that makes gutka or pan masala even more dangerous than traditional tobacco. The psychoactive substance, again, I'll confirm it's the same, it's nicotine, but the additives are different. That is how tobacco is different from gutka.
Thank you, sir. The next question, again towards you, is a lot of countries have legalized cannabis. In your opinion, is this right or wrong?
Wrong, absolutely wrong.
Okay, I think that answers the question pretty much, but
yes.
Sir, please continue.
So the kind of complications, and I'm not only talking about the psychiatric complications of cannabis. So frequent cases of testicular cancers, of cardiopulmonary complications that we come across in people who consume cannabis. I don't think recreation warrants the cannabis to be legalized if we look into all these complications. Psychiatric complications, I can name hundreds of complications, so common that people have had one recreational use and they end up in our psychiatric ward with schizophrenia. So even a single use of cannabis can precipitate or unmask schizophrenia. And once you are diagnosed with schizophrenia, probably it is a lifelong diagnosis. So again, I would reiterate that considering the harms associated with cannabis consumption, it absolutely makes no sense in legalizing cannabis in our country.
Okay. The next question is for Dr. Prajakta. Are you there, Doc?
Yes.
Yes. So again, this is in regards to cannabis use only. Is that in our country also, cannabis in oral form is being or starting to be accepted as a pharmaceutical agent? Your thoughts and opinions on this?
Right. Like Dr. Parijat also said, yes, there are people who do explain their cannabis use as a medical use, or for which is they do say that it is a outside it is a subscribed medication, and our doctor has also told us, but not really. I don't think that's the case usually. Oral cannabis has been there. I mean, the use has been there for a very long time, but yes, access to cannabis for younger and younger kids has become easier. Also, there is a lot of Western influence where cannabis is considered to be more acceptable than alcohol or smoking, and there are a lot of people who do promote it for mental well-being or physical well-being, but there are, like Dr. Parijat just mentioned, even as there are people in which even a single exposure can lead to hazardous mental health consequences. So
Thank you. Another question, Dr. Prajakta, back to you is what is your strategy to deal with resistance, especially in teenage adolescents with quitting smoking or nicotine abuse, basically? What would be your like go-to strategy? Because we face a lot of, to elaborate further on the question, we face a lot of rebellion when it comes to teenage patients. How would you go about that, or how different would that be from normal counseling?
right. So, like I mentioned when we were speaking on the topic of teenage addiction, most of the teenagers or most of the adolescents, you are going to find a rebellion. You are going to find a lot of resistance with regards to taking any sort of help. They might come to you if and when they realize that it's becoming a problem, which might again be too late. So what we try to do is when the kids come in, usually it will be the parent who has dragged them, or maybe the school has noticed that he or she has a vape in the bag, or maybe in some way they have been caught. Don't don't attack them with your that this is a problem and we need to solve this. This is extremely unacceptable, because that has probably happened at home any which ways, that has probably happened in school any which ways. So when they look at you or they come to you, if we are going to do the same thing, it might just be even more, it might just be the same to that adolescent. So you need to focus on building a rapport with the child. You need to focus on making them also heard. Why are they doing such a thing, and what are their challenges? There are a lot of adolescents who have probably even tried quitting, maybe, but we just assume that they are hooked onto it. There are times that probably they have just tried it out of the novelty because the other peers are doing it. So our job is to not assume that they are full blown addicts and they really need a lot of help. Maybe it's not the case. So what we do is, yes, hear out the parents, hear out what they have to say, and then keep them out, talk to the child by yourself, and try and understand where the child comes from, what are they kind of facing, what are the challenges that child is facing, and have they do they really want help. So approach it with that strategy, that do you really think that you need help, because most of them are going to say no. So in that case, you tell them, okay, then let's figure out a way to get your parents off your back. So the child may feel that you are you are on his or her side. So I know it sounds like a lot of task, but that's what works, because if the child understands that you are on his or her side, it's a lot more easier to work with them. So talk to the parents alone, talk to the child alone. Don't talk to them together, because when the parent is going to talk, they're going to tell you a lot of horrible things about the child. Many of them may not be true also. So, and the child would not like hearing that there's a complete stranger and my parent is just complaining and blabbering and saying all the bad things about me. So talk to them separately. When the child comes in, to ask them whether they need help. And before doing that, of course, build a rapport. They don't like you when you approach them as a patient. Just try to get to know them. What school do they go to? What college do they go to? What are their? I know it might involve 10-15 minutes of your time, but that really helps. That initial icebreaker really helps in forming a good rapport with the child. And don't be in a hurry to get them off maybe whatever substance that they're doing, because it's not going to happen in a hurry. So rather than that, take your time, keep calling them, maybe for dental checkups, maybe for your counseling, keep calling them. There will be a time where they will start discussing that problem with you. And the parent and the teachers have already been extremely judgmental towards them. So try to, as far as possible, not have a judgmental outlook towards them.
Absolutely. I believe that also empowers them, that they believe that they are in a safe space, and maybe the output and the outcome might be greatly affected by that. Thank you. Thank you, Dr. Prajakta. My next question is towards Dr. Akshay Ranade, sir. Sir, the first part of the question is, are nicotine vaccines FDA approved?
They are still in the research phase, so they are into the clinical trials. So I don't think so they are FDA approved, because FDA approval comes after your human trials. So they are in the third tier trial system. So according to your any drug manufacturing or any drug that shelf process is concerned, you have the animal trials, human trials, and then it goes on to the shelves of the pharmaceutical, outside the pharmaceutical companies. So yes, definitely FDA non-approved, but they are in the pipeline.
Right, sir. Thank you. The next question is a slightly long one and has many parts to it. So let's go by one. The first thing is, this is like a situational question. After NRT, the patient says that instead of nicotine, now he's addicted to the drug. That's part one. Part two is, what would be the ideal, guidelines and protocol for pharmaceutical management? Are there any drug reactions with any of these drugs, both in replacement and non-replacement? And what effect would any comorbidities, any existing comorbidities have? And the last part is, what is the form of consent that you would need, and is it easily incorporable in your regular daily dentistry?
So as far as, should I answer?
Yes, sir, please, all yours.
As far as your addiction to the drugs is concerned, there's no addiction to non-NRT therapies. There is, yes, definitely there is addiction to NRTs, because nicotine replacement therapy contains nicotine. The non-nicotine replacement therapies don't have nicotine. So there's no question of addicting to the drugs like Bupron or Champix or whatever. So as far as NRTs are concerned, yes, definitely. As I had mentioned in my PPT also, that we have a lot of tsunami of patients coming and saying that we are now hooked on to, we have left cigarettes and we are hooked on to the gums. So that is another a different ball game altogether, and it's a major game changer, I believe, because we need papers and research papers and the randomized control trials for, checking as to how do you de-addict the patients from the gum therapies, and how to go about that. It's still a very gray area. As regards to your second is how to avoid drug reactions if patient presents with comorbidities. Yes, for your tricyclic antidepressants and this thing Bupron, you will have to take a thorough medical history. Definitely, comorbidities are strict contraindications for those drugs. For NRTs, it is okay. I mean, of course, I mean, as far as your neurological deficits are concerned, comorbidities, you will have to take a medical consent. But NRTs are pretty safe. I mean, if you talk about the severity of the drug reactions are concerned. And consent for NRT, yes, you have to take. It's a thumb rule that you have to take a consent for both NRT and non-NRT, drugs. So I hope I have answered all three.
Sir, rightly so. The last question I have here before we end the Q&A session, it is open for all three speakers. Kindly shed some light on recycling habituates. Is that what the term is, or have I got it wrong? And how to manage relapse in such conditions. Is the term right, or I don't know. Hearing it for the first time, sorry.
I don't know, maybe Parijat is the expert on the addiction. I don't know if there is such word like recycling habituals.
Even I am unable to figure out what the
It
question
reads, I'll
actually.
spell it out for you. It says habituals. Habit
Recycling
के बाद
habituals.
habituals. I have also heard the term for the first
I
time.
have heard. I'm hearing it for the first time. Dr. Ray.
Okay.
Recycling habituals. I have to read about it.
Right. Whoever's put that question, I'm very sorry. We can't really comprehend the question. But yes, if there is anything we can do to solve it, we will definitely get back to you on this. Keeping that in mind, I think it is time I give the vote of thanks. First of all, big thank you to the Bombay Psychiatry Society for having agreed to collaborate for this program. Thank you so much, Dr. Shobha Nair, Madam and team. And thank you, Dr. Parijat and Dr. Prajakta for such great insights today. Secondly, our own IDA Thane, Dr. Manisha Lad Madam and her team, obviously, and Dr. Akshay Ranade, very much our own. So thank you so much for being a part of this today. And definitely, the team at ICPA Clinical, thank you so much, everyone, especially Dr. Rajiv Chitgupi, sir. He is the one why all of this is possible. He is the one why all of this is happening. And thank you so much, sir. We owe it to you. In effect, we shall conclude this session. And if there is any feedback, you can get back to us at your respective teams at BPS or IDA Thane on what else can be done to make it better. Thank you so much, everyone. We'll conclude this session now.
Thank you. Thank you, everybody. That ends
Thank you
today's
so
session.
much.